So I'm going to be doing some interactive discussion today. So you will see these high-tech cards in your pack. So I want to do a bit of a dry run and get to know you all. So if you're a dietitian, could you hold up the orange card? Everyone's getting out their coloured cards now, see? And if you're not a dietitian, could you hold up a grey card? You see, this is the good dry run. Okay, like a sea of orange. A sea of orange. So, can you keep your card up if you had extra cake at lunchtime? A lot of dietitians. So, my name's Nick, and I'm a dietitian at the Royal Hampshire Hospital. Last year when I presented, I showed you this picture of our wonderful hospital in the sunshine. It is sunny in Yorkshire, and I encourage you all to come to our clinic, which is there. It only seemed fair that I actually show you a picture of my department. So there we are enjoying a healthy, nutritious lunch. And what I really like is the balance of good health is just in the background there. So I'm going to talk today about new dietary treatments in non-responsive celiac disease. And I think about the role of the dietitian and how we play an important role, not only in diagnosis, but in treatment. I'm going to relate to a couple of different dietary approaches. So, has anyone heard of this, the 3 Ds of celiac disease? So back in the midst of time, what would happen is patients would come along and get diagnosed with the appropriate serology and the appropriate histopathology. And then they would see, hopefully, a specialist dietitian that would give them an individualised diet. They would be encouraged to join Coeliac UK and maybe a local group. And then they would get discharged ecstatically through the door, never to be seen again, to adhere wonderfully 100% to the diet forevermore. Now, of course, we know that's not a realistic picture. Even in patients that respond well to the gluten-free diet, we're not sure of the best way to follow those patients up. In some ways, that's a different talk, but we know the evidence would suggest that most patients like the idea of seeing a dietitian, and they like the idea of an access to a specialist doctor as needed. And what we're hoping to see is a reduction in serology, a reduction in tissue transglutaminase, an improvement of endomysial antibody, and ideally, this is a bit controversial, but an improvement in duodenal mucosa on repeat biopsy. I think internationally, the idea of repeat biopsies is much more accepted. In the UK, maybe we don't do it too much. But particularly in patients that do not respond, we have to think about the importance of this. The way I like to think about it, again, this is a little bit controversial, is serology is secondary and mucosal measurement is mandatory in some patients. So I think when we're thinking about specialist diets in terms of super sensitive diets or other forms of dietary approaches, our clinical practice needs to be led really by the most sensitive marker we have, which is duodenal biopsy. So, what is non-responsive celiac disease? It is a bit of a diagnostic and therapeutic challenge in some ways, but essentially patients appear unwell, apparently adherent to the gluten-free diet. And if you never respond to the gluten-free diet, that's considered primary NCD. If you respond, but then get a little bit worse earlier on, then you are considered at secondary NCD. And emojis are the way forward in clinical talks, I've decided. So, there's an established medical pathway for diagnosis of NCD and exploring it. And the goal medically, it looks very complex, that side, but actually it's split down to 4 bits. Establish and clarify diagnosis. Sometimes celiac disease can be misdiagnosed. Obviously, patients then need to be looked at if there's any co-occurring or other conditions going on. Maybe they've got small bowel bacterial overgrowth, maybe they've got pancreatic insufficiency, and of course, they may consider refractory celiac disease. But essential to all this is diet. Most of non-responsive celiac disease is gluten-driven, either by patients including gluten in their diet, or they're super sensitive and they look like they're adhering, but they're just very, very sensitive to gluten exposure. So even in refractory disease, diet is considered important. If we think about type 1, that's the more serious presentation, and that film just down there on your right is a lymphocytic picture in duodenal biopsy. And the important thing about type 2 is it's to do with aberrant monoclonal lymphocytes. That's what's driving that are present over time. It's not a snapshot picture. They need to be repeated in patients who have those clinical symptoms. And a lot of these patients can actually end up requiring parenteral nutrition. But what I really want to focus on is type 1. The important thing with type 1, that picture, that slide just down there on your left-hand side, is the scalloping and sort of nodular appearance that you would see on non-responsive celiac disease. Non-responsive celiac disease in terms of type 1 and refractory type 1, there's a fuzzy line. Even the doctors and the trialists and the way they've studied it, there's a very, very fuzzy line between refractory type 1 and non-responsive celiac disease. And I would argue that in refractory type 1, again, a lot of it is diet-driven. If you get the diet right, a lot of these patients would get well. Now, have we got any evidence for that? Well, I want you to think about the most strictest form of gluten-free diet you can think of. And this has been done with this fascinating study. It's a Scandinavian study, and what they did with these patients who were refractory type 1, they put them on an elemental diet for several months. And it doesn't get more gluten-free than that. Anyone who's tried elemental O28 in the room will know that it's a very serious thing to be on, and it takes a lot of dedication to do it. But what they showed after a few months on an elemental diet, this is pre-elemental and post-elemental, is a substantial amount of mucosal recovery. So the important point here, what this is showing, if you get the diet right, if you get people strictly gluten-free, they will get better with our RCD type 1. So I think dietitians play a massively important role here, particularly in diagnosis. If you think what we do in clinic, we get anthropometry measures, we get serological measures, we will get diet history, we may do quality of life measures such as the CDAC, and we measure ongoing other symptoms and review things like DEXA scan results. We can tell if a patient's not responding. And the important thing is we can triage as necessary through informal or informal routes to the gastroenterologist for further investigation. So we play an important role in diagnosing these patients. But I think we really need to think about how good we are as assessing gluten exposure. So we're considered the gold standard. If you look at all these quotes from various places, dietitians are considered the gold standard for gluten assessment. And how good actually are we? I have to say I've particularly highlighted this because they committed the cardinal sin of spelling dietitian with a C. They're refractory to the correct spelling. So this is a seminal paper from Dr. Woodward, who's in the audience today, so no pressure for me to get this right. And the reason why it was seminal is they looked at how good dietitians, they looked at a number of different factors here. They looked at several sort of surrogate markers of villus atrophy, if you like. And what they identified was 94 patients with persisting villus atrophy, and about 69% of those cases, dietitian could identify a cause. Were pretty good. However, what they noticed that basically about 50% had ongoing VA, ongoing villus atrophy, and they felt that probably dietary assessment fails to identify a lot of gluten exposure. But that's not to do dietitians doing their job wrong, it's a surrogate marker. And if we look at serology, serology again is a poor surrogate marker for testing for villus atrophy. In this study, it was about 44% sensitive. And I think this is because with assessment of gluten is a bit like this famous quote from this guy, Donald Rumsfeld. There's things we know, there's things we know we don't know, and there's things we don't know. And that's a little bit like the gluten assessment in many people's diets. So sometimes it goes really well. Here's a case study of a patient presenting non-responsive. She's got ongoing TTG, elevated elemental antibodies, and she had a biopsy of Marsh grade B. Now, the dietitians in the room will look at that diet history, and what will you say straight away? Yeah? And now, it's obviously not good that she's been cross-contaminating herself, but when that happens in clinic, you're like, I can help. And sure enough, this patient did improve once she'd had some ongoing further instruction in dietary adherence. However, you will often get patients like this case here. Again, positive serology, Marsh grade 3A. She was generally asymptomatic, but she was having, obviously indicators of ongoing problems. And her diet was pretty perfect. She had a very healthy diet. She was very aware of the principles. And what is really going on here? Well, we can try and maximize, I think, the way that we're doing things dietetically. And I'm open to all forms of suggestion. I've learned a lot from various colleagues over the years. But this is kind of the things that we do. Of course, we will rely on the diet history. And I often get told I should have been a medic with handwriting like that. But we also do food diaries, which can be really useful. Obviously, the problem with that is patients maybe misreport or may miss things, depends how involved they get. What I have learned from my sports dietetic colleagues is food diaries. Most people have access to a camera phone, and it can be quite good for accessing brands. One thing when you do this, you get to know people that may be using Instagram and maybe not. The other thing that I like to use is a dietary adherence questionnaire. So we use the CDAC, which is the most probably specific one. I think it just gives another range, another angle on things when you're looking at assessment. And of course, as we've heard today with the work of Dr. Herrera, it may all change with gluten immunopeptides in the future. So what is going on? I think one of the things that means that we can't assess these patients probably is sensitivity. It's gluten sensitivity and the range of sensitivity. It does exist on a spectrum. So if you look at this systematic review from 2009, they suggested that a tolerable amount for gluten may be ranged between 10 milligrams to 50 milligrams a day. But we know that it can go down maybe to less than 1 milligram in some patients. A lot of these are based on case studies. My personal favourite is this Italian one. 1 milligram of gluten a day keeps mucoval recovery away. And this was a case of a lady who was having Holy Communion every day. She was getting communion wafers every day. And they were analysed, and that was having about 1 milligram of gluten in it. And that was enough to cause her symptoms and villus atrophy. So we know this can be an issue. And there is some good news. This is a study hot off the press. It came out in January of this year, and it's looking at the evolution of gluten content of cereal-based foods. And what you notice here is different legislation comes in. What they've looked at is the percentage of samples that are over 20 parts per million, 20 milligrams per kilo. And you can see it's got a lot better. And this is foods that are certified gluten-free or just labeled gluten-free, but it has dropped. So that is good news. The thing is, it's not that simple a picture, and I think this next study is really, really important, and I found it fascinating. So this is a Dutch study, and what they did, they looked at the amount of gluten products consumed, related to parts per million, and the amount of exposure. Now, if you look at 200, 100 million, that would be considered sort of the low gluten area that we don't really use in the UK, but you can see you can very easily get up to 60, 80 milligrams of gluten a day. The interesting thing, if you look at the 20 milligram cutoff, you can see that for some patients, most patients on average when they're eating labeled gluten-free products will consume about 400 to 300 grams of those products a day. And you can see you can very easily, maybe if you were super sensitive, get up to a level that could be problematic. Now, it is important to say a lot of the companies, most of the companies test way lower than this, but 20 parts per million is the cutoff in Europe. Interestingly, in New Zealand and Australia, the cutoff point is the lowest they can detect. So as the technology gets better, that drops. And at the moment, the lowest they can detect is about 3 parts per million. But it's a big move. It's controversial. In Australia and New Zealand, they want to maybe review that to be in line with other countries. So I think this is really important. Now, what's in a name? I don't know about you guys, but I'd be interested to hear. I've heard the super-sensitive diet referred to in all these ways. Wheat-free, gluten-free, super-sensitive GFD, a no-gluten, gluten contamination elimination, a naturally gluten-free diet. I don't know if you've had referrals maybe with these different things. If you look in the literature, you will see all these things. And I think sometimes we're talking at cross purposes, or we may be. So I'm not a gambling man, despite this photo of me and Dr. Curran at BAPEN conference last year. But I would like to ask you, which one of these diets you think may be a super-sensitive diet. So you've got the different colours there related to your cards. A, these are all gluten-free diets, so A is a low-fibre, low-lactose. B is a wheat starch-free, gluten oat-free and barley malt-free. C is a wheat starch, gluten-free, oat-free, barley malt and grain alcohol. And then D is grain-free except for rice, no processed food and milk-free. And after 3, which one of these diets do you think would be a super-sensitive gluten-free diet? It's not a trick question, honest. Or is it a little bit? So takers, I reckon most people are going orange. Most people are going orange? Yep. So the ones that have been looked at in the literature are B and D. So B is called an SSD, a super sensitive diet, so that avoids Coeliac wheat starch, gluten-free oats, and obviously barley malt. And obviously what that's doing is removing more gliadin, it's removing avenine from the oats, and it's removing any potential hoarding potentially in the diet. The other one in D is a GCED, a gluten contamination elimination diet, which is a lot more strict, if you like. Now, this slide's a little bit busy, but I do want to talk about this a little bit more. So, super sensitive approach, like I was saying, Coeliac wheat starch, barley malt, and gluten-free oats are out. Now, referring back to that Dr. Woodward study you did earlier on, those 94 patients with persisting villus atrophy, where they couldn't identify gluten in the diet, they put them onto a super sensitive diet. And of that group, what happened was about 62% got in mucosal improvement. So once they put these patients who they couldn't detect gluten in, they put them on a super sensitive diet, and 62% of them mucosa improved, and 82%, sort of about 38% had ongoing villus atrophy. So it can work, it can improve the situation. Now, this gluten contamination elimination diet, I just want to ask a very quick question. If you hold up an orange card, if you've ever heard of it. Blank. Pretty much no one. Interesting. So this is a very, very strict diet. So it's no grains apart from rice, white and brown rice, no processed foods, and no dairy for the first 4 weeks. You can have fresh fruit and vegetables. You can have fresh meat, poultry, oils, vinegar, honey, and some other juices and things like that. That's pretty much it. Now, the results from this were published from America. In America, it's called the Fasano diet because it was published under Alicio Fasano's group. And what they did, they looked at about 17 cases, patients with persistent villus atrophy who were non-responsive to the diet. And after about 3 months of this GCED, 82% had normal mucosa. And of that group, 78% could return to a normal GFD after being on this diet. So there's some indication that when you're healing, you may be more sensitive. When your gut gets better after taking the gluten out of your diet through this super sensitive approach, you can then return to a normal diet. But it's very, very restrictive. I want to ask one more question again. How many people looking at this diet would want to put one of their patients on it if you hold up an orange card? Not very many people. Yeah, you've got to select your patients. So I currently have 3 patients who've tried this approach. 2 of them managed 3 weeks and had enough. It was affecting their food-related quality of life. And I've got 1 patient currently on it who seems to be tolerating it at the moment. I think maybe it has its role. I've asked you that, all right. So I think with this approach and with the different diets, we can relate it back to different symptoms. So we've got patients who have no symptoms in a negative biopsy. There's no argument there. Those people can be reviewed annually, maybe in primary care. We've got people with symptoms but positive biopsy, or no symptoms and positive biopsy, then symptoms and a positive biopsy. These people, they may be ingesting gluten in what we consider a normal way, or they may need a super sensitive approach. That may be a standard super sensitive diet, or maybe a GECED if necessary. But we've also got these patients who are negative with ongoing symptoms. They have a functional, maybe, difficulty. And we know from previous studies that celiac disease and IBS can correlate. If you go down to an IBS clinic, you will pick up celiac disease more than you would in the general population. So sometimes they can be misdiagnosed, obviously. People with celiac disease can be misdiagnosed as having IBS, but we know the two can interrelate. And what we wanted to do was maybe see if other dietary treatments, such as a low FODMAP diet, could help. Now, this is one room where I don't have to explain what FODMAPs is, but obviously it's fermentable oligosaccharides, disaccharides, monounsaccharides, and polyols. I often tell the patients if they can say it 3 times a row, they will win a prize. It's a complex intervention that is not a diet for life. We will all know this. I'm preaching to the crowd. I don't know how many of you, may be interesting to ask the question, I don't know how many of you have had patients maybe turn up to clinic with an A4 sheet printed off the internet, or have maybe been told to go and look at Google to go onto this diet, and have maybe put them on themselves on a strict low FODMAP diet for a long period of time. This is not a good thing. It's a dietetic-led intervention. It's a snapshot for 6 weeks, and then the diet is reintroduced, and then it's a personalization process. So it is a dietetic-led technique. And I just wanted to ask that question. Do any of you currently use the low FODMAP diet on your celiac patients? We do an orange card. So a few of you. That's good. That's good. So we wanted to do this approach. But the first thing I did want to emphasize, like I was saying, is a low FODMAP diet is not easy or risk-free, as Professor Volta was just alluding to. We do use first-line advice even in celiac patients who, their mucosal's normal, they've got some gut symptoms. It's important to use the BDA first-line advice if that's appropriate. Not all patients, so sometimes it feels like we live in a low FODMAP echo chamber where if someone's got a gut problem, they need to go onto a low FODMAP diet, but it's important to consider first-line advice as well. We know that the low FODMAP diet can have effect on things like iron and calcium in the short term. This is a study by Kings, by Heidi Stordaker, and they did notice a drop in iron on a low FODMAP diet in the short term, in the exclusion phase. And we know, again, as Professor Volta was alluding to, there's a substantial body of evidence now that suggests the low FODMAP diet negatively affects the microbiome in terms of bacterial load and distribution of the microbiota and the reduction of things like biofidus bacteria. So it's important that we do this carefully. We wanted to see how well we were doing, so we did a case note review, and we included, it's only 14 patients, so it was low numbers, but we looked at patients with ongoing symptoms, were on 3 criteria that completed the diet for about 4 weeks. We excluded patients where we used a first-line approach, and there was other medical diagnosis, or they're on a super sensitive, or they continued mucosal damage. And this is the basic demographics. Essentially, obviously, there was quite more female than men. There was one patient with a weekly positive EMA, but they did all have a negative biopsy, and they're the normal BMIs generally. So we used the gastrointestinal symptom rating scale that probably most of you will be familiar, that we use in terms of monitoring symptoms in the low FODMAP patients. We particularly focused on the two most presenting symptoms: abdominal pain, discomfort, and distension. These patients predominantly had IBS-D and celiac disease. And we also asked the global satisfaction question: do you currently have satisfactory relief from your symptoms? I don't know about you, but I'm not sure where this came from. I have very few patients that come into my clinic and go, Nick, you know what I really want? Satisfactory relief from my symptoms. Well, they come in with symptoms. They come in with bloating, distension, flatulence, and those sort of things. But this is the question that is asked. So, the global symptom, yes or no? Well, what we showed in our patients, and this is at the end of about 4 to 6 weeks of low FODMAP diet, 57%, and at the beginning they were all saying no, none of them had satisfactory response. At the end of it, 57% did, 43% didn't. Well, you might think that's not a particularly good result. If you relate it back to the largest randomized controlled trial that's been done in the low FODMAP diet, that was done in the States last year, this is Dr. Che out of the States, their results were pretty similar to ours, so sort of a 50% reduction in that global symptom question. So we also looked at abdominal pain and distension, and this is our groups, both our groups. This is abdominal pain, and this is distension at baseline and follow-up. And you can see this significant drop. It was quite impressive, really, in terms of abdominal pain and reduction in terms of distension, and they were both statistically significant. I also wanted to briefly discuss this Norwegian study, because when you have a good idea to study something, you find out someone else is doing it as well. So this is a Norwegian group that looked at a similar thing. They had 40 patients, and what they did in here was very important. They had an active comparator. So they had 20 patients. These are all patients with normal mucosa, and they had 20 of them on a super-sensitive diet and 20 patients on a low FODMAP diet, and they used the IBS severity scales. The interesting thing about here, I just want to present a couple of bits, is these patients, their FODMAP content dropped for some of them majorly. They were on a low FODMAP diet potentially at the beginning, but it dropped to maybe 1 or 2 grams a day. That is incredibly low. And they still reported massive reduction in symptoms, in bloating severity, and also an improvement in daily activities, like a sort of quality of life measure. And I think this is interesting because particularly wheat, barley, those sort of gluten-containing grains get labelled. The reason why people with non-celiac gluten sensitivity improve on a gluten-free diet is because they take the fructans out. They take those sort of things out of the diet. Look at these patients. They were on a gluten-free diet in the beginning, and you took fructose and other things out, and they still improved. I'm not sure we can always label the door at fructans, and particularly grain fructans. I think there may be other things going on as well. But certainly in this cohort, compared to the super-sensitive approach versus the low FODMAP diet, the low FODMAP diet did work much better. So this is our protocol that we tend to use in Sheffield. Essentially, in terms of dietetic review, if someone's got normal mucosa and a Rome 3 criteria, we will follow that sort of obviously first-line advice, and if necessary, we'll then go to the low FODMAP approach, personalise it after review and then annual review for their celiac disease. If they have got villus atrophy and symptoms, then we would look at a super-sensitive diet, and we are now considering the gluten contamination diet in some selected patients. So I've put this up. This is one of our celiac group clinic photos, and I put it up because we need to think about the patients at the end of this pathway. We know that a gluten-free diet can affect your quality of life in relation to other conditions. We know that following a gluten-free diet can be difficult. We know that following a low FODMAP diet can be problematic in terms of your health-related quality of life. You put these two things together, it is very, very difficult for the patients. To do this properly, we're seeing more patients diagnosed with celiac disease. We're going to see more patients diagnosed with non-responsive disease. And really, complex diet needs consistent dietetics. We need to be given the resources and the time to see these patients properly. And I'd like to end by just thanking Coeliac UK and all my colleagues for giving me the opportunity to talk.
Lovely. Okay, so thank you very much, Nick. I have to say those Photoshop classes that we sent you on have really got put to good use there. Couple of questions for Nick. Anyone got any burning questions for Nick in the audience? Show hands over the top corner, Nick.
Hi, Nick. That was a really interesting presentation. How do you think as dietitians, we can reduce the variation in dietetic practice across the UK, building on the work that you've got? I mean, what is the role for the BDA, for instance, and how can we ensure and how do we manage that?
Wow, that's a lot of questions. Well, in 10 seconds, I think we need to think about novel ways of working. Obviously, a lot of people are doing low FODMAP groups now. I think we do need to be selective about the patients that we see in terms of we need to be seeing the more complex cases in terms of, people who have done FODMAP training. But we need to think about how patients can access this in terms of maybe medical technology. It may be online things, it may be apps. We need to sort of embrace modernity. And we need to think about realistically in the current financial situation that we're all in. But what we want to do is make it safe for the patients, not people having A4 bits of paper on with the low FODMAP diet and being on the restrictive phase for months. It's not an easy question.